Hello, everyone. This is the third and final event in our series co-hosted with the Endowment. I want to introduce our speakers. I'm not going to have them join us on camera just yet, but I do want to share that we have a wonderful panel for you today. We have Colleen Flynn of Build Healthy Places Network, Valerie Martinez of Blue Shield of California, Len Nichols of Urban Institute, and Susan Phillip of the California Department of Healthcare Services. Before we get started on the discussion, I would like to formally acknowledge how wonderful the Endowment has been in co-hosting this series. And I want to invite our partner from the Endowment, Marisol Aviña, to open this discussion with some remarks about why we're here today. Marisol.
Thank you so much, Joe. Good morning or good afternoon, depending on where you are tuning in from. On behalf of the California Endowment, I am excited to welcome you all to today's webinar, which, as Joe has mentioned, is the last in the series. And we want to thank the Blue Shield Industry Initiatives team for the partnership in bringing together these virtual spaces and very rich conversations over the past few months. I personally have learned a lot from these webinars. For anyone that is joining us for the first time or who may not be familiar with the California Endowment, we are a statewide health foundation that funds, supports, and partners with community-based organizations and leaders across the state that are working to achieve a transformed and inclusive health system, a reimagined justice system that prioritizes prevention over incarceration, inclusive community development, and a just education system that dismantles the school-to-prison pipeline and promotes healthy school environments. Because we know these and other social drivers contribute to overall health and well-being. Addressing the social drivers of health requires coordinated efforts across systems, payers, purchasers, community organizations, policymakers, and many others to achieve the necessary policy changes, innovations, and ultimately systems transformation that will make this work possible. We have heard over the past two webinars and will likely continue to hear today common themes about the interconnectedness of three essential components for addressing social drivers of health: workforce, data, and payment. Having an adequate, culturally and linguistically diverse community-based workforce is necessary to move towards a health and wellness system. Similarly, securely connecting data is critical to drive decision-making, target supports equitably, and improve health outcomes. And today's conversation is focused on the third and very important component, which is payment. We pay for what we value, and that is the case in our personal lives as it is in the policy space. As policy conversations continue about how our health system is financed and any potential reforms, such as unified financing, what many of us hope to see is a health financing approach that truly transforms the health system and pays for not only clinical care, but also the community supports that we believe can make a significant difference in improving health and well-being. California has leveraged opportunities and options to innovate in various ways and to explicitly incorporate and pay for linkages to social and supportive services. From the whole person care pilots to the health home program, which TCE was involved with, to the new Medi-Cal health plan performance and system innovation. And of course, CalAIM, which we will hear more about from our amazing panel today. It is an exciting time in California with all these various efforts and initiatives that have the potential of expanding what we pay for and what we value. We also know there is much work to be done, and it will take all hands on deck to ensure the success and sustainability of these efforts that will ultimately improve the health and well-being of our communities. So, as you hear from our panelists today, I encourage you to think about how you can partner with organizations in your community. And what can you personally do to advance this work? It is more effective and efficient to work together, both to help meet the needs of individuals and to impact the community level social drivers. Thank you again so much for joining us today. I am very much looking forward to this conversation. And I will now turn it back over to you, Joe, to get the conversation going.
Thank you so much, Marisol. I just love that you ended your comments with a call to action about what we can all do to partner in this space. I just think that I hope that's a theme throughout today's discussion. You know, Marisol, you have been such a pleasure to work with. And I would also like to thank Bonnie Madura and Dr. Bob Ross, also from the endowment. It's been a privilege to work with you all. And we so appreciate you for opening each of these 3 events. And we would not be here without you. So thank you. Okay, so I would love to have our speakers each introduce themselves and join me on camera. So I'll turn it over to each of you. Let's start with Susan and then go to Valerie, Len, and wrap it up with Colleen. Susan, you want to get us started?
Great, sure. Thanks, Joe. Good morning, everyone. My name is Susan Phillip. I serve as the Deputy Director for Healthcare Delivery Systems at the Department of Healthcare Services here in California. My role includes overseeing 3 divisions, 2 of which oversee our Medi-Cal managed care program in the state. So this includes managed care operations, managed care quality and monitoring, and then integrated systems of care, which really oversees and supports our home and community-based waiver programs and other programs such as our California Children's Services and PACE organizations. So as Marisol alluded to earlier, DHCS is currently implementing a major transformational initiative called CalAIM, which stands for California Advancing and Innovating Medi-Cal. And this is really our long-term commitment to transform and strengthen Medi-Cal. And a core goal of CalAIM is directly aligned with addressing social drivers of health. So specifically, one goal is to identify and manage needs of our Medi-Cal members by really taking that whole person care approach and addressing and assessing, social needs of our Medi-Cal members, and then aligning and identifying programs that could support members to achieve improved outcomes. And just as a reminder, Medi-Cal covers 14 million Californians. So that's 1 in 3 Californians are covered under Medi-Cal. So, really our investment and transformational efforts really does impact our healthcare delivery system in the state. And just real quick on a personal note, I joined the department in April of 2021. I've been in healthcare for over 20 years in various roles. And working with health plans, consulting, and at the federal government on Medicare payment policy. And in my volunteer time, I serve on boards of community-based organizations. Right now, I'm on the board of an organization called Safe House in San Francisco, which provides transitional housing and support services for women who are survivors of trafficking and sexual exploitation and experiencing housing instability. So that's just a little bit about myself, and I'm just, it's really exciting time to be at the department. We're really rolling up our sleeves and really working with partners throughout the state. So I'm happy to be with you all today. Thank you.
Good morning, everybody. My name is Valerie Martinez. I currently serve as the Chief Health Equity Officer at Blue Shield California Promise Health Plan. In this role, I'm working to implement upcoming state mandates that Susan just implemented, but also implementing a very robust, comprehensive health equity program, which will include identifying disparities and then addressing inequities and inequalities that we've identified. And during my 16-year tenure working in both the federally qualified health center system and in managed care settings, I feel like I've observed and had a front row seat to looking at the changes in data collection and payment methodologies, and then even following the current evolution of state mandates that are now going to facilitate the move from treating patients, which I would say within the confines of a 4-walled exam room, to now a more holistic approach that best serves an individual's social, emotional, and medical needs. And Blue Shield California Promise Health Plan is working to do just that, in addition to implementing innovative programs that will help us to meet the CalAIM requirements Susan described, but also go above and beyond to best meet our members' individualized needs.
Thanks so much, Valerie. It's a real privilege to have you here today as a colleague. I know this is your first time joining an industry initiatives event, but we hope this is the first of many to come. Len, you want to take it from?
Thanks, Joe. I appreciate that. I'm a simple country health economist from New Orleans, but I'm attached to, thankfully, the Urban Institute's Health Policy Center. I began my career working on insurance market reforms during the Clinton administration's attempt to expand coverage. And then as the ACA was being formulated, I figured out that basically if we don't turn to delivery system and payment reform, then we're not going to be able to make healthcare affordable, and we might reverse those coverage expansion gains we're all excited about. And then after the ACA passed, I realized that if we didn't get serious about social determinants and equity, then our entire social structure could collapse. So I did what economists do, Joe. I found brilliant co-authors and developed models and frameworks to illustrate that the many benefits of collaboration, which does not come naturally to some organizations in our highly competitive and individualistic society, those benefits of collaboration are much larger than people think, as Marisol said. But I'm quite sure I'm the happiest 69-year-old health economist in the country because of what I'm doing in this social determinant space right now. Our models have health plans, hospitals, law enforcement, AAA, CBOs, health departments, and community information hubs cooperating upstream in communities as diverse as Cleveland, Ohio, Waco, Texas, Albany, New York, because these organizations know they should, and it turns out their missions and sometimes even their bottom lines are improved if they do collaborate. So thanks for having me here today.
Thank you so much, Lynn. Really glad to have you here. Colleen, you want to take it home for us?
Thanks, Joe, and thanks for having me today. It's great to be here with you all. I'm the Senior Director of National Programs at Build Healthy Places Network, and tomorrow I will be the Co-Executive Director of the network. And we're a national organization that works at the intersection of community development, healthcare, and public health. And our mission is to help transform the way organizations work together to more effectively address social determinants of health that we'll be talking about today, and also advance racial equity across the country. And I do this work because growing up, we moved every couple of years. I was actually born in Iran, and I really longed for deep-rooted and connected communities that I didn't have. And I believe this work, thinking about moving upstream, giving people choice and opportunity to live their lives in a healthy neighborhood, can help get us there. And I appreciate the other panelists and the learnings that I'm sure I'll have today too. Thank you, Joe.
Sounds like congratulations are in order for you, Colleen. Really happy for you. And thank you all for being here with me today. So let's get the discussion started. So I will direct questions to each of you, but feel free to jump in and respond if you sort of want to build on each other's comments. So Colleen and Valerie, let's start with you with a couple questions. So what do you think it takes to sustainably fund collaboration between healthcare and communities to address both social needs and then also those upstream drivers or factors in health and well-being? We know that referrals and cross-sector collaboration are essential. So can you share any sort of innovative examples of funding to support that type of work? Colleen, you want to start?
Yeah, Joe, thanks. Yeah, at Build Healthy Places Network, we think that healthcare and public health partnering with community development sector is one of the silver bullets. Community development is about building wealth, economic development, and prosperity. And healthcare, as we know, is increasingly investing in creating health and well-being in neighborhoods. And a lot of times community development and healthcare are working side by side in the same communities with the same populations, but they're not necessarily doing it together. And by our estimates, the healthcare industry spends about $3 trillion annually on preventable diseases that show up in historically marginalized neighborhoods. At the same time, the community development sector invests nearly $400 billion annually into historically marginalized communities, addressing important social determinants of health, like affordable housing, schools, career pathways, healthcare access. So we really think that, for healthcare to invest in more upstream measures and working alongside community development will be really helpful. And when we say, address an upstream measures, I guess, what we think is that we see a lot of healthcare somewhat still thinking and focusing on the social needs. And so, we kind of want to see that move to supporting more community-wide efforts, addressing more of the root causes, and getting more upstream, as I was talking about. We also think it takes these sectors coming together to invest in community-led and owned approaches, where residents can identify, co-create, and have ownership in the solutions. And for us, community ownership is critical to creating social determinants of health investments. It's important to ensure community members have agency in the changes happening in their neighborhoods and with their healthcare, and that the owners are a part of that change. We see that when residents are unable to fully participate in the decisions that impact their communities, it excludes them and makes long-term sustainable change harder and reinforces existing inequities. So one example I wanted to give is St. Alphonse, a nonprofit health system with 5 hospitals in Idaho and Oregon and a member of Trinity Health. They partnered with Leap Housing, an affordable housing developer, and Indy Dwell, a housing builder, to develop Idaho's first community land trust. The land trust model allows owners to own their homes, gain equity, and maintain affordability in that home. And the hospital system contributed an initial investment of $250,000. And that investment has created a fund of $2 million to have more community land trusts all throughout Idaho. They've also been involved in a lot of important policy change that allow community land trusts and those types of models where it's community owned to flourish in the state of Idaho. Thank you very much.
Sure. Really appreciate your comments in particular on really putting communities in the ownership and the driver's seat on this. I mean, historically, institutions of power like health plans haven't really been in that focused on that or moving in that direction. So it's really wonderful to see you all out there, pushing us and crawling us in the right direction on that one. Valerie, sure. Valerie, I know Blue Shield has done a lot of work in this space, so would be curious to hear your perspective, and then if you want to talk about some of the initiatives that we've done.
Sure thing. Great question. So for purposes of speaking about social drivers of health and innovation, I think first we should acknowledge that we know there are multiple challenges to be able to launch such a large task and program. So some of the challenges include data collection, integration across various EMRs and platforms, and integrating all that great data that hopefully we will collect or are collecting, and then also being able to implement and evaluate large-scale programs so that we can address these social drivers of health. And at Blue Shield, we're working to address those and also simultaneously working in parallel to launch a series of innovative and collaborative and cooperative programs. So I'll share with you some examples where we have implemented some really great programs, including community partnerships and also value-based programs. So Blue Shield California Promise recently launched pilots that incorporate community health advocates, network providers, our community-based organization partners, and value-based payment models to help close gaps in equity and also address social determinants of health. So we develop partnerships with providers to design workflows that integrate community health advocates into the actual care model. And this allows us to tap into a myriad of data sources to help identify those marginalized members who might be able to benefit from direct one-on-one support from a community health advocate. And in partnership with our providers, we created and designed workflows that help integrate community health advocates as a member of the care team. And this positions them to be able to provide the most value to our members and to be able to also support our providers. And we used criteria such as community level social risk, member claims diagnosis, healthcare utilization, and inequities to identify those who are most marginalized and again would benefit from that one-on-one support. We also recently implemented a holistic health payment model to help close gaps in equities and our inequity. Blue Shield also tested methodology that pays practices per gap closure, and most recently also incentivized stratified reporting on self-reported data such as race and ethnicity. So we're working to develop a closed loop bi-directional network funding model, and that will help support our community-based organizations who provide regional services. And organizations will be selected based on their ability to impact social needs as determined by an area's key partners, community health advocates, and then also use of Blue Shield's My Sidewalk Neighborhood Health Dashboard. And this dashboard is really great. It features tools that highlights specific social drivers of health and provides a baseline to be able to assess impact over time. And as we know, the social sector might be described as fragmented and in some cases under-resourced. And so we know that we have a variety of ways to best support organizations. And as an example, in outcome data to date, we know that our community health advocates at Blue Shield have serviced over 5,000 clients and helped to create nearly over 8,000 referrals to community resources using examples of those platforms. So we've forged some really great partnerships with organizations, including Kaiser Permanente, Common Spirit, Community Healthcare Foundation through the Unite Us platform. And we also work very closely with 211 San Diego to implement referrals for social needs. And these efforts help to link our providers and Blue Shield community health advocates to hundreds of organizations locally, regionally, across the state. And now we can track, we can refer, we can assess capacity for service delivery. And some of these resources include food banks, housing, youth centers, legal assistance centers, child service organizations, and more. And we know that about 80% of health is happening outside of the healthcare system, which is why we're investing in a statewide network that'll allow us to pay for social services because they too are providing healthcare services. And lastly, just one other piece which I think is really important is the Z code component. We know that collection of Z codes has been wholly dependent on providers voluntarily submitting codes. So Blue Shield has maintained the ability to collect Z codes related to social needs for several years. We're developing plans to increase the rate of Z code submissions through training our providers, communication with our provider network, and beginning with our Medi-Cal providers. So Blue Shield has also partnered with the California Primary Care Association to network and to be able to offer some of coordination with electronic health record vendors so that we can then integrate and optimize the workflow to be able to support community health clinics. So really that's kind of the focus now, right, is that collaboration, the referrals, and then Z codes are the coding for the data that's submitted to the health plan so we can look at descriptors of members and patients when they come in for healthcare.
I really appreciate that last comment. That's such a perfect segue to our next question. But first, before that, I just want to reflect a little bit and say that one theme that I'm hearing is that it's clear that a lot of folks have a role to play here, in particular workforce, but that also data and infrastructure are really key facilitators. And we are fortunate to have Susan, a leader from California Medicaid, on here with us today. And I'd love to get her thoughts about California's approach to data and the policy at play here in the state to drive forward this work. But before I pass it to Susan, I just want to provide a little bit of context. So California, as Valerie mentioned, is encouraging providers to use Z codes to capture social needs of patients, and some health plans are paying providers to collect these data. So let's talk about how payment sort of supports the collection, use, and sharing of social needs data and data on drivers' health as well. So Susan.
Sure, thanks, Joe. I really appreciate Colleen and Valerie's comments and highlighting challenges that we've had to date as well. So before I get into data, let me just first start by saying, Medicaid in general, right, has had to consider social needs of our beneficiaries, really since the inception of the program. I was just recently at our National Association of State Medicaid Directors Conference, and really all the state Medicaid programs all agree that, the social needs of our beneficiaries and kind of figuring out that way to work across sectors, across health and social services really has been a challenge for many years and something that we're all working towards. We know that for Medi-Cal enrollees that have the complex healthcare needs and unmet social needs, they're at high risk for all kinds of issues, right? For hospitalization, they're at higher risk for institutionalization. We know, for example, people experiencing homelessness have higher rates of diabetes, hypertension, HIV, and are at higher risk for morbidity and mortality. And there has been, barriers under Medicaid in terms of federal restrictions on direct spending on social services. So as a federal program, Medicaid is can't directly spend money on certain social services. However, there has been flexibility and clarification by our federal partner, Centers for Medicare and Medicaid Services, under current law to address social drivers of health. And CalAIM is really a manifestation of some of that recent flexibility through our Section 1115 waiver and our 1915B waiver. So I'll get into that in just a little bit, but let me now go back to your question on data. So, I think we all agree that getting a handle on who really has those social services needs is really important. We need systematic methods for data collection. So Valerie alluded to those Z codes, and there's several Z codes out there under the ICD-10 codes. And what we did as a department, just what we clarified is in our all plan letter, which is guidance that we as a department provide to our contracted Medi-Cal managed care plans. We clarified a list of priority Z codes. So that way we're really supporting the plans in their guidance to providers, their contractor providers, to say, focus on at least these 25 priority Z codes that will really be helpful for us to track as a system, so that we can really focus on those that also track to benefits and services that are available under CalAIM. So these are the ones that we really see as ones that we can really prioritize and they're actionable. Then going back to CalAIM, I do want to focus on a couple of services that are under CalAIM that really are designed to address social drivers of health. First, enhanced care management and community supports. So enhanced care management is a new benefit. It's a new Medi-Cal benefit that went live January 1, 2022 under CalAIM, and it's really designed to support comprehensive care management for members with complex needs. So this is not intended for everyone, but it's really for that really top 1% of folks who have lots of healthcare needs and other social services needs, and really often have to engage with several delivery systems just to access care. There are several populations of focus who may qualify, but to provide a few examples, they would include individuals and families experiencing homelessness, high utilizers, and individuals with serious mental illness or substance use disorder. The whole concept of ECM is to address both the clinical and non-clinical needs of the highest need members through that intensive coordination of health and health-related services and social services. It really is intended to be high touch and meet members where they are, whether it's in their homes, whether residential facilities, or, in their doctor's office. And the idea is to have one care manager to really coordinate the needs of the member. And I do want to touch on community supports, because that's also where we really are pushing the envelope on social services and really addressing social drivers of health. So community supports are a set of pre-approved services, there are 14 of them, that Medi-Cal managed care plans are strongly encouraged to provide. They're not required to provide it, but they're strongly encouraged to. And these services are those that are considered substitutes for other services such as hospitalization or skilled nursing facility or emergency department use. So they're considered cost-effective, medically appropriate alternatives to healthcare services. So a couple of examples: housing transition and navigation supports, recuperative care, asthma remediation. So these are all services that are can be provided directly to the member and potentially reduce other types of costly healthcare services. So, if you provide an individual recuperative care, or sometimes called medical respite, that can help individuals who, maybe don't need hospitalization, but still need time and a safe place to heal, from an injury or an illness, but maybe their living environment is not stable. And, having them discharged directly into the community would only exacerbate their condition. So providing a space for recuperative care can really reduce, unnecessary length of stay in the hospital, but lead to better outcomes. So those are a few examples, and I will make sure to drop a link for more information.
Thanks so much, Susan. Policy is such an important point of leverage to drive this work forward, and really glad to have you on the call and to share that perspective. So Len, all of the comments today, and in particular your opening comments, have made it clear that folks across the entire ecosystem have to meaningfully collaborate, right? And particularly on this idea around payment for data infrastructure and workforce. So partnership is the mindset, it's a mantle, it's a philosophy that we ought to take on. And I recently read an article you authored on the idea of co-opetition in this space. And I know you've also done a lot of work to build an economic model that's sort of predicated on this idea. So would love to hear your perspective on all that.
Well, thank you, Joe. But first, I have to say, I wish all our Medicaid programs were as ambitious and well-led as California's. I mean, wow, Susan, I guess you don't sleep much, but it is impressive, just so you know. In my view, requiring Z-code collection and all the activities Susan just mentioned are preludes to collaboration, to permit the assessment of population realities and community needs. And I see two major areas where planned collaboration are needed and possible. And the first is the one you talked about. Stuart Butler and I wrote a paper about essentially infrastructure, that is to say, community connection infrastructure. And we think there are two important elements to that. One is technology, obviously, the referral platform capacities, but also trust. And we don't talk about trust enough. I know everyone on this call and probably everyone listening is deeply aware that everything moves at the speed of trust. And if you don't have trust, technology is worthless. So at the end of the day, you need to think about infrastructure in that two-dimensional component. And Stuart Butler and I published this paper in American Journal of Public Health because we thought, you know, plans need to consider a concept we call, or that has been labeled, co-opetition, which means collaborate in some areas of the supply chain and include upstream all the way as part of the supply chain for health, and compete in others while you continue to do that downstream for members and employer clients and so forth. And the reason we think this will work and is so important is because of self-interest. It turns out it's cheaper and better for all, especially for the CBOs, the absolute essential front line in this health and social service ecosystem we dream of building. It's essential to collaborate on infrastructure rather than to build 6 or 7 different infrastructures alone that silo everybody into relationships with one plan. And that's why we think this kind of idea is spreading. Clearly, you're hearing about it in California. It's spreading around the country. We think it will be more common over time. But the second area where collaboration is really important and indeed essential is in financing the social needs themselves, not just the infrastructure, but the actual services. And that's where my other brilliant colleague, Lauren Taylor, assistant professor of population health at NYU's medical school, and I have made a model, we call it CAPCHI, Collaborative Approach to Public Good Investment, which is both a funding model and a governance structure for sustainably managing joint projects that are upstream. Healthcare can't pay for everything, but healthcare organizations are in a unique place to discover the genuine social needs of their patients and enrollees. And with a little more creativity, like the California Medicaid program is showing through CalAIM and PATH and all that, healthcare could and should begin to pay for health, Joe, not just healthcare services. And paying for health gets us much farther upstream into people's real communities and real social needs. So our model we call CAPCHI was designed to enable groups of stakeholders to overcome what we call the free rider problem. That is, when activities naturally benefit multiple organizations and people downstream. And when that happens, things like permanent supportive housing, which might lower health plan costs, hospital costs, might also reduce law enforcement needs, local government, business community, et cetera. They each benefit if others invest, so they all kind of hold back and no one invests enough, or then maybe they do a little charity around the edges. That's why we have too little investment upstream in social services in general. And what our model does is elicit confidential value expressions and then assigns prices to those stakeholders that they feel are fair and sustainable in relation to the value they receive from the project at hand. And this value can be both financial or mission driven. The key question is, will the participants feel like they're getting enough value relative to what they paid in? And it turns out Cleveland, our very first community to do this, to implement, has just agreed to do a second year. So we're pretty optimistic about the kinds of collaboration you're hearing about today spreading around the country.
Thanks so much, Len. I so appreciate the idea of co-opetition. I mean, that's the whole sort of model and philosophy that Industry Initiatives has pursued. Our team, I mean, we are really building on this idea that we can and really should be working and collaborating in a meaningful way with our competitors, to create and build on public goods, right? And that's honestly what healthcare fundamentally should be, is a public good. So we've covered a lot of ground so far, and I'm thrilled because, as you've heard from a few different folks, this is a third in a three-part webinar series on social drivers and social needs. The first, as we've said, is focused on workforce and data, and both of those have come up throughout the conversation today, as well as payment, which is obviously our topic at hand. So fantastic to hear all of these themes really come together across the whole series into a cohesive paradigm. So I would like to ask each of you what you think is the most important to move this body of work forward. Like, who needs to be at the table? What do we need to keep all these organizations at the table, right? We want them involved, we want them committed. Return on investment and value creation is certainly one motivating factor, but what else should the audience be thinking about? Len, I actually think let's start with you.
So the single thing you want to change, I would say we need to get our governments to pay for health. That is to say, to empower and require healthcare organizations to think about health and not just healthcare services. And that would change the fundamental dynamic. It should put all the right stuff in the MLR and all that technical stuff, but it should change the incentives so that everyone has a common interest in solving community problems. You can't just address hunger by giving people food. You've got to address the root causes of that, Joe. And to do that, you've got to have a holistic view. I love this language of ecosystem, this language of collaboration, co-opetition. I feel like we're on the cusp of actually getting it in our country. And so the way to think about that is we need to make a pipeline for people to come from where they are to where we want them to be. And that means good jobs. That means thinking hard about paying livable wages. That means thinking hard about training programs and getting people the support they need. All this ecosystem comes together, but it all starts with, we got to pay for what we value, as Marisol said at the beginning, and what we value is health, and health is multidimensional.
Susan, I wonder if you have thoughts here.
Yeah, just addressing upstream drivers of health and well-being is no small task. We really need everyone at the table, including, from the department's perspective, right? Our plans, all our partners, and we need to think about other organizations. I think, I'm putting in air quotes here, non-traditional providers, but, folks that we have, that provide social services, are community-based organizations that have the experience in providing social services and understand their community and who has what needs. And we need to integrate them more into our delivery system. I do want to touch, Len actually alluded to this one program path that we have underway also under CalAIM. We talked about enhanced care management, community supports, and these are services that we're looking to scale over the next few years. But we know that there's going to be time that's needed, right? There's capacity that needs to be built up, infrastructure that needs to be built up. Organizations that haven't traditionally worked with managed care plans need to understand how to work with managed care plans. Because these programs are administered through our Medi-Cal managed care program. So PATH is a set of funding, stands for Providing Access and Transforming Health. And DHCS has received authorization of $1.44 billion, really to maintain, build, and scale infrastructure that's really necessary to ensure successful implementation of ECM and community supports. So just really quickly, there are three main initiatives I do want to highlight under PATH. First, we have a collaborative planning and implementation program. The whole idea there is we have regional collaborative planning efforts throughout the state. There are facilitators that DHCS has selected, individual organizations such as CBOs that are interested in working in regional collaboratives can go and register and then be connected with a facilitator in their region. And the whole idea there is for organizations to come together to identify gaps and really prioritize goals for scaling CalAIM. And the next is called CITED, which is another acronym, which I won't get into, but you can remember CITED. And that's really an application-based process. The idea is for CBOs, providers, organizations that are interested in building capacity can complete an application. And the idea is to provide funding for infrastructure and capacity building. So permitted uses include, say, developing and modifying your billing system. If there's provider workforce that needs to be funded in the short term, that could be done as well. And then finally, we're going to have a technical assistance marketplace that will go live at the beginning of next year. And the whole idea is for organizations that really need that hands-on technical assistance can go onto the website, which will be an online marketplace, and can find pre-approved set of vendors to find that technical assistance. So the whole idea of PATH is really to provide that startup money, if you will, to help build that capacity over the next few years.
Thanks so much, Susan. Colleen.
Thanks, Joe. And thanks, Susan. It was great to hear too, just that you also agree that kind of non-conventional sectors and organizations can be involved in the success of all the work. And I think at Build Healthy Places Network, another thing we think about is just the idea of multi-sector partnerships to create the conditions for equitable health and well-being. And we've actually developed a playbook for multi-sector partnerships, and it has lots of strategies and case studies of creative partnerships impacting what we kind of think of the framework that we like to use as vital conditions, and thinking about social determinants of health and how to think about local economic prosperity, housing, infrastructure that helps bring access to important healthcare needs. And for us, we think about partnerships and the different shapes they can take and connections across institutions. And, it can be challenging because organizations have different perspectives, incentives, motivations for collaboration. But they also have unique and valuable skills and resources that can be leveraged. And so that can be the impact of bringing different sectors together. And as I was mentioning, one useful framework that we've adopted is the 7 vital conditions for well-being, the project of the Well-Being Trust, because we think every sector can kind of identify if it's humane housing, if it's healthcare access, whatever that might be, they can identify one of those 7 vital conditions. And another thing is that when we think about the framework, as I was talking about before, we think about the levers we can use for community change and to think about the environments to address social determinants of health. And so again, we really believe that community voice is the center. So thinking about meaningful engagement with the community is a way to kind of really establish that foundation. And so, a lot of health plans, a lot of this work involves community engagement strategies. So how can those be really impactful, meaningful, and authentic, and lift up, stories that showcase integral data points of what's really happening on the ground in these communities? We also think about a lot of times just kind of the inclusion and self-determination and wisdom of all the community members that this can bring. So I think that the playbook was just shared. A couple of other things that I would say that I would just like to highlight too is that, we also have thought about a lot about social drivers and social needs and thinking about policy changes. And so actually with the help of Blue Shield of California Foundation, we created a policy scan that looks at policies that advance collaboration around advancing health and racial equity and healthcare's role in that. So I think there's a resource that we wanted to include around that as well that might be helpful. Thanks, Joe.
Thank you, Colleen. Valerie, do you want to take us home on this question?
Sure, sure. To echo what has already been said related to policy and having the downstream and upstream entities at the table, I think we can all agree that we're so fortunate in California to have a Medi-Cal program that's implementing policies and mandates to support these objectives. Thank you, Susan. But we know that this is just one piece of the very complex pie. And so we need to have those folks at the table so we could talk about policy change, payment methodologies, considerations that are required to operationalize these mandates. And so we need to have a very robust group of folks at the table to learn from their perspectives and incorporate some of those really important considerations so we can understand limitations and opportunities that still exist. So we need buy-in from stakeholders. Much of this work and this change is going to challenge historical scopes of work, right? We talked about helping providers understand that their role is going to evolve to include a focus on non-medical or other social needs. And that's going to be really important to get that buy-in from the providers. And then coupled with the payment for reporting Z codes, we can now use that as a tool for advancing that evolution in their scope and embedding those new workflows to help to tie together the data and the workforce. So we'll need some sustainable financing. That'll be key to driving behavior change over the long term, meaning that funding streams should also be considered a long-term need, not just kind of one funding offered at one point in time, right? We need this to be sustainable and long-term. So we know that value-based care can allow greater flexibility in terms of services that are delivered to help us provide accountability for this long-term sustainability, but also to improve population health as a whole. So we have models that incorporate variables that represent social determinants of health, right? So we should leverage that existing data, the way that those mechanisms are used to collect that data to be able to minimize burdens on practices, right? We're anticipating that there might be a burden with that data collection. So helping to use maybe one assessment tool, one screening tool that's been validated and adapted specifically for the population served, rather than requiring CBOs to implement a new tool for looking at specific data collection, working with health plans to engage individuals and CBOs so that we have the tools that are trusted, that are valid, and make it a lot easier for providers to be able to collect that data. So hearing that challenge about data collection, we might think, how are we going to capture this data? How will we report this? How will it all be integrated? So we'll also have to leverage the health information technology platforms that can help to facilitate social drivers of health, that data collection from medical records and other sources to be able to integrate that to help improve clinical decision-making, care coordination, quality measurement, and then at the end, ultimately impact our population health. Those are really important. There's just one thing I want to say that I think that we're looking at integrating these interventions and really banking on seeing reduced utilization, clinical costs, right? But it's going to take time to be able to see that. And really, we might even see savings starting to accrue in other systems, right? We might see an impact on the criminal justice system, education system, child welfare systems. So tracking outcomes across other systems, not just the healthcare system, might also help to influence our policymakers to account fully for the savings and the benefits of program and delivery reforms. I think that that's really important.
Thank you all so much. Would love to transition to some audience Q&A. And I love this first question because before I ask it, I should say, as we reflect on this idea of partnership and collaboration, obviously trust comes up. But the other thing that really comes up for me is the ability to learn from each other. I think that is really a core sort of function or feature of what it means to build trust is really the ability to listen and learn from each other. So in the spirit of that, our first audience question from Bridget. Thank you, Bridget, for this question. I love it. For the states that are not in the same advanced stage as California, and yet still want to drive impact and positive change in this area, where do experts recommend we focus our resources? I welcome anybody's thoughts, but Colleen, I wonder if we could start with you.
Yeah, sure, Joe. I think that's a great question. We've actually been doing a lot of research on that. I guess in my point of view, I'm going to go back to what I've been talking about. I think it would be leveraging the assets that community development sector has, because they can bring a lot of resources to the table and have, federal money, state monies, local monies to think about kind of overwide health in a particular neighborhood. So you're welcome to reach out to me. I can leave my contact information, but I'd say reaching out to community development organization partners and to kind of the finance sector would be key. Yeah.
wonder if any other panelists have any thoughts on this question.
So living in Louisiana and having lived in Virginia for 30 years, I can say there's quite a few states not quite as far along as California. Look, you got to start where you are. But what is true is that every state has communities where they have these incredible assets. It might be a world-class AAA leader. It might be a really good housing agency. It might be a really good public health director. And the point is you build, in a way, awareness around where your assets are. So start a conversation. Begin asking your docs, what are you responsible for? You know, are you responsible just to make sure the suture's straight? Or are you actually responsible for the person's health? And they're going to say, I want to fix the suture and go away. And you're going to say, no, we got to think about the health. No, you don't solve it alone. And here's a partner to teach you what their life is like after they leave your office. And by the way, why they keep coming back. So I think this notion of focusing on community, focusing on existing assets, there are wonderful players in every place, and have them teach the healthcare sector how to interact with society as a whole. Public health can help, but start with the communities you got.
Yeah, I totally agree. I think that ties to some of Valerie's earlier comments as well. Valerie, do you have any thoughts about other states? I mean, like California obviously is doing quite a lot in this space, and you have a legacy doing this type of work. Any thoughts about what others in other states can do to get started, including, starting with our local community partners?
Yeah, I've done a lot of research on this topic, and I think that it's important to consider the challenges and the needs at that state level, right? What are the priorities? And then getting resources mobilized to agree on a common vision. I think that's really important starting with the state that this is what we're going to do. It's a priority. It's not a pet project. And this is going to be a long-term scale project. I think that's really important. And then you start building the drivers to be able to get there to accomplish that. And that includes cascading the vision down to partners, CBOs, health plans, and then trying to figure out how are we going to do this? And then the mandates always help, right, to get the work done. But I think that it really starts with creating that common vision and then understanding what's needed to be able to execute that plan.
Yeah, Susan, I mean, you've done this work, right? I mean, from that state level. So you have that experience of building these programs sort of more or less from the ground up. And I know you can take advantage of some earlier work on this topic, but I mean, California is huge, and it's really a revamping of the way that we think about healthcare. So any advice you'd give to other policy leaders in their states?
I agree with the comments that's been shared thus far. I really also think that, even starting with the local hospital, I mean, there's so many appropriate, there should be incentives for a hospital discharge planner to ensure that you're not seeing the same person cycle in and out of your emergency department. So I think those are some very key examples, even starting with saying, hey, who's that person who just keeps using the emergency department as their primary source of care? Identifying those individuals, working with care managers. I mean, I think those are, in my view, low-hanging fruit, kind of identifying those local hospitals and where you can identify those members, and you can make a huge impact just even starting there.
Thank you so much. Well, we have just a couple minutes left. I'm going to see if I can squeeze in one last question that we got from the audience. The next question is around what data is or should be collected. We've talked about day codes, obviously, but what are some other examples of data that organizations should be collecting to support, this effort to address social drivers, particularly using payment innovation? Valerie, we could start with you unless anybody else wants to jump in.
Sure. I think it's going to be important to understand that we're just getting started, right, with this data collection process and payment methodologies. But I think one important consideration is going to be the health outcomes, right? So how do we know? We might know that we're capturing a need, we're screening for social needs, and then referring to social services. But I read about this term called the bridge to nowhere, where we have all of these really great support systems in place. We're referring patients and they have a connection. But what are the outcomes? Is it helping to improve outcomes? So I think that another important element of capturing that data is looking to see, was the loop closed? If they were referred to a food bank, did they actually go? Did they get food? We're not just stopping the process at the point that we've referred them to a food bank, checking the box. It's looking at really, did the patient, did that individual get their needs served? And I think that's going to be a really important element to begin collecting as well, so we can begin to assess the impact on health outcomes.
Yeah, oh, please, Susan, I saw you take yourself on mute. Jump
Yeah, I would just like to also add, just another kind of very specific example is how we could possibly integrate our housing specific data. So, to the extent, there's HMIS systems all around the country. And how do we really get access? How does our healthcare system have access to that information so that we could clearly identify individuals that have housing insecurity and that, those are folks that are prioritized in the system, so it's just a very tactical way that I think we could try to make some immediate improvements. And I did also want to mention, under CalAIM, as you mentioned, Joe, it is huge. I didn't get into all the aspects, but and I believe you had prior speaker DHCS also speak about our population health management service. So hopefully, and not going to go in this year, but it's going to be a service where we are looking to integrate different sources of data from encounter data to social services data, and that could be a unified platform. Ambitious undertaking that we are working on now.
Colleen, I see you're off mute. Do you want to take a quick second? We're almost at time.
I know that we're at time, and just to build off what Susan was saying is that the way we think about it is take a holistic approach with data. So housing, thinking about poverty levels, thinking about job retention, all of that can kind of build out the whole community. And we have a site that provides a lot of different data resources if anybody wants to look at it. Thank you.
Yeah, we'll make sure to get all of it. Take a look in the chat. We've got a lot of content and links for you in the chat, but we'll also follow up with you all if you want to look for any specific content. I just love, we're at time, so I've got to cut it up. I hate cutting off such good discussions, but I'm going to wrap it up. And thank you all so much for your engagement today. If you haven't done so, please don't forget to register with your email so you can get the recording, and you can even forward that recording to folks who missed. Just a couple thank yous. This is the end of the series with the California Endowment. We're so thankful to the endowment, in particular Marisol Aviña and Bonnie Madura, for your partnership. Thank you all to our panelists as well. And finally, I want to acknowledge Muriel Lemoy, the mastermind behind this whole series. She has been working tirelessly behind the scenes. And I want to make sure all of you know that Muriel is to thank for bringing all of this together over the last few months. So thank you, Muriel. Okay, so remember to follow industry initiatives, sign up for our newsletter. You'll hear more about all of the great content we have coming out. And we look forward to seeing you all soon. And hope you all have a wonderful and restful holiday season. Thank you. Bye-bye.